In the upcoming set of parallel panel discussions, we have a public sector panel discussion on State Blueprint, Technology Roadmap for COVID-19 Vaccination Drive, Supply Chain Management. This will be moderated by T. Radhakrishna, Editor South, ET Government. In Audi 2, there will be an enterprise panel discussion on ripple impact of AMR during COVID-19. Is it a disaster in making? This will be moderated by Pratibha Raju, Assistant Editor, Digital Content, ethealthworld.com. Over to you, Radhakrishna and Pratibha.
Hi, welcome to the panel discussion, State Blueprint, Technology Roadmap for COVID-19 Vaccination Drive, Supply Chain Management. The ongoing vaccination for needy, continuation of public health services by 24/7, readiness for the future crises, including third wave of 2000 COVID-19 pandemic, and strengthening the capacities and medical resources across the states are some of the priorities of the state governments at this juncture. The Government of India has taken ownership of distributing vaccination to all the states as per their requirement. However, the question arises on the state governments how to strengthen the supply chain strategies to receive, store, distribute, and manage COVID-19 vaccines, and to enhance the medical infrastructure to ensure the quality, efficacy, proper tracking, reporting of vaccine utilization, and safety of COVID-19 vaccine, as well as prevent the wastage of vaccines. The panel discussion will discuss these important areas focused on health blueprints for the state governments. To lead the panel discussion, I am joined by Mr. Bhaskar Katamneni, a 2004 IAS officer, Commissioner and Department of Health and Family Welfare and Mission Director, National Health Mission from Government of Andhra Pradesh. Dr. Darez Ahamed, 2005 batch IAS officer, Mission Director, National Health Mission, Government of Tamilnadu. Mr. Bhuvnesh Pratap Singh, 2012 IAS officer and Project Director, Jharkhand State AIDS Control Society, Department of Health, Medical Education and Family Welfare from Government of Jharkhand. Dr. T. Arun, 2013 IAS officer, State Health Secretary, Puducherry Union Territory. Gentlemen, welcome to the panel discussion. So my first question to you, Mr. Bhaskar, what is the status on the ground as far the vaccine drive is concerned, and how your state is aligned with the Government of India's the inventory plan of vaccine delivery system?
Thank you, Mr. Radhakrishnan, and I also thank ET for having us on the panel, and warm wishes to all the fellow panel members also. First of all, let me clarify certain things that there is nothing called a state-specific plan for COVID vaccination. It's a single system that is operating across the country. The COVID platform is used, and that is the only platform that can be used. So a little bit of a change in the flavor of using the COVID in terms of local physical management of the COVID vaccination is possible. Otherwise, in terms of IT framework, it's the same across the country. That's both an advantage in one sense and also has certain disadvantages in another sense. The advantage is that it's a large network that we have today, and which is being used across the country in every village, every PHC, at every facility. And on a real-time basis, we are able to track the vaccine from end to end, from the time the vaccine reaches the state to the end beneficiary vaccination can be tracked on the COVID platform. And over a period of time, with the initial hiccups that we had, now it has matured to a level that it has been now a large number of APIs have been created, which we have integrated with our own local state-specific packages, state-specific portals and all. to enhance its usability and also adaptability, and it is evolving as we speak too also. So it is a pan-India thing. There wouldn't be much any state would be able to do, except that utilize the network, utilize the system to enhance its usability. That is one thing I just wanted to put before the members of the panel. Of course, all the members of the panel have been using this, and so they're all very well aware. This is for the viewers that are going to participate in the discussion. So it's the same network everywhere, the same portal, same network. And the beauty is that it is device independent. You can use it on any device, and it can be used at different levels. And till date, it's working fine with so much of data flow happening. We didn't have much of hiccups till date. A little bit of initial hiccups were there, which is expected from any system. But now it has matured, and it is the largest, I think, vaccination IT system that is there anywhere in the world. These are the initial remarks from me. Thank you.
Thank you. Thank you, Mr. Bhaskar. Dr. Darez Ahmed, welcome to the panel discussion. Can I have the latest status on the vaccine drive in Tamil Nadu and your experience, please?
See, Tamil Nadu, we have vaccinated 2.2 crore, including first and second doses. So Tamil Nadu has been trying to use, we have more as sir was saying, from Andhra Pradesh secretary was saying, that we don't have the supply chain, everything is standard. What we use for universal immunization program and COVID platform, the system which we are using for our vaccination system also. But what Tamil Nadu is trying to do is to have a vulnerable population coverage and trying to push, for example, postnatal mothers, mentally ill, vulnerable population. And today also we had this mentally ill vaccination drive, wandering mentally ill, homeless wandering mentally ill vaccination. And we try to cover the NCD more vulnerable population. That is a strategic decision state has taken, and to cover tribal population, like for example, the district of Nilgiris, we are trying to cover the whole tribal population, and already it's in the. So what Tamil Nadu has been trying to use the resources which we have to cover the vulnerable population and the population which has most exposure, like street vendors, shopkeepers. So that's been our strategy in the vaccination system, so that we get the maximum coverage and the most vulnerable and exposed people have protection with the doses which we receive. That's been our strategy for the vaccine management. Supply chain management, it is standardized. As I said, we have a strong supply chain system, Tamil Nadu Medical Supplies Corporation, and the vaccine system is integrated. And COVID portal, as you know, is one of the biggest systems anywhere in the world. So that part is standardized, but in the usage part, we try to cover the vulnerable population as a priority.
Okay, thank you, Dr. Darez Ahmed. And Mr. Bhuvnesh Pratap Singh, welcome to the panel discussion. Sir, can I have your initial remarks on the latest on vaccine drive in Jharkhand state and supply chain issues?
Thank you, sir. First of all, I thank ET for having this panel discussion, worthwhile panel discussion. I also thank Bhaskar sir from Tamil Nadu and Darez Ahmed sir from Andhra Pradesh, who has given their opening remarks. Sir, as far as Jharkhand is considered, and rather as what both the earlier panelists has told us, we are somewhat different as far as these things are, because our state is not as urbanized as Tamil Nadu, or I'll rather say Andhra. We are totally hilly state, and as we are all aware, we have the issues of Naxal issues are also there. So our strategy is not what I can say that we are getting the vaccine and we are just using it. Till now, our target population above 18 plus, which have been allowed, is 2.40 crore only. And we have till now vaccinated more than 90 lakh people. So now this much effort we were able to do based on the detailed and planning that is done through IC activity. We have some 15 to 16 tribal population in the sub areas. For that, we have planned different IEC activity in their local regional languages we are reaching. As far as portal and all are concerned, we are using the COVID portal only. But above all, as I'm sure all the panelists will agree, the way we are going for vaccination depends on the availability of vaccine from the center. So the moment we get vaccine, we start going for vaccinating people. Initially, there were hiccups. Few people were not ready to get vaccinated. We had to do a lot of IC activity. And in fact, we have involved all our local political masters as well as our officers. They went to field. We had, in fact, I'll say during this time of COVID, we even organized the Gram Panchayat and Chopals to inform people that it is a useful activity. Now we have gone we have allowed all the media personals, everyone who has joined us in this IC activity. So now we have a huge demand for vaccine. And I'm sure the moment we get more vaccine, we'll be able to vaccinate people. That's initial remark from my side, sir.
Thank you. Thank you. Dr. T. Arun, welcome to panel discussion today. Sir, we all know that the COVID-19 pandemic has accelerated the adoption of technology, not only in healthcare, and most of the verticals in the government functions. What has been your experience dealing with the technology in health subject, especially in your Puducherry Union Territory?
I agree, about your question that there is a lot of technological intervention, especially during this COVID pandemic. Since I'm also from the medical background, I know the entire, I studied my medical sciences. Usually the technology used to be only in the terms of, in olden days, it used to be only in telemedicine, and that too only one particular part of diagnostics. Apart from that, there were no major technological interventions. Thanks to COVID, we have increased our technological intervention. For example, even monitoring in the beginning, because I have seen both as a secretary health and also as a district collector in the first wave and the second wave, how we used to track patients, how the entire dashboard, the home isolation monitoring, we involved the technology. The IVRS system, through even the app-based home isolation monitoring, or be it the dashboard to make the beds availability to the general public, oxygen availability to the general public, a lot of technology, and even quarantining, tracking the patients. So technology has helped us a lot in this COVID, in this entire COVID. And of course, right now we are seeing the involvement of technology in vaccination. The COVID portal, which has been made by the government of India, is tremendous. You can track who has taken first dose, second dose, category, age wise, how much, real basis we come to know, and how many has skipped the second dose, and who has taken here and who will be taking in somewhere else. So all those things can be tracked with the help of this technology. Technology has made a very, very, very major. Today we can't imagine COVID vaccination without portal, without that technology. IT portal. So technology has been the game changer, I can say, with respect to the entire healthcare management today.
Thank you. Thank you. Mr. Bhaskar, we hear that some southern states have deployed drones as a pilot to distribute vaccine to inaccessible areas on a pilot basis. Any experience of Andhra Pradesh deploying or using the drones on pilot basis?
No, Mr. Radhakrishna. I think there's a misconception. I think people think that vaccination is something we are starting new. No, India has the largest vaccination network anywhere in the world for our routine vaccination. COVID has just happened and COVID vaccination has come. But we need to be aware that our routine vaccination, from polio to measles to general BCG vaccination, is a very well-established network wherein there is a cold chain system that operates from an India level to state level to district level and sub-district level up to your PHC and sub-center. The sub-center is the lowest level where your cold chain is there. From sub-center again, the vaccines are moved in the cold chain small boxes to the remotest corners. So even to islands, even to the hilltops, we have a large number of habitations in particular districts which are hilltops, which basically takes 2 days of trekking from the nearest float point. But that vaccination, routine vaccination for all the vaccines that I'm talking about are happening there before the COVID struck us. So we use the same network. So it's a very well-established network that we have, which is called EVIN. Now with COVID, we use the same kind of backbone to make it a COVID. The physical network remains the same. We have this the refrigerating vehicles, and then we have also the refrigerators where these can be stored and then transported up to the last mile. I don't think there is a requirement of using drones as such because of the extensive network that we have. The remote areas we know, so we move the stocks there well in time for any vaccination drive. And during COVID also, that is taken into consideration, and our cold chain moves that way. So the only addition that we have done this time is that for all the smaller vehicles also this time we have fit in the GPS devices. So in real time, we are able to track which vehicle is where, so that we ensure that the vaccine doses reach those points at the appropriate time. Because this time the challenge has been that every time the kind of vaccination we need to do and the doses we receive are generally good enough and sufficient enough, and there is a time. We have for example, for pulse polio program, all the vaccine doses reach a state well in advance, a couple of weeks before, and they reach the PHCs at some centers at least a week before, and a day or two before the actual vaccination itself, we kind of do dry run, and a day before vaccination, everything is tightened, and on the day of vaccination, the boxes move. In COVID, what has happened is that there is always this problem of mismatch between the requirement and the availability. If I require X number of doses on a given day, I will not get X, I will get little less than that. So managing becomes a little critical. So the time is of the essence, and we try to ensure that they reach on time, so that whoever people who have booked their slots, because there is a booking of slot system also. So people book their slots, a demand is created. To meet the demand, we need to push the vaccine to the last point, equal to the demand that is created there in time. So that becomes critical, but I don't think the use of drone technology is being used, or for that matter is really that essential to take care of the exigencies that we face right now.
Thank you, Mr. Bhaskar. Over to Dr. Darez Ahamed. What has been your experience related to drone technology? We know that Chennai Corporation and Chennai Smart City engaged the drones for the non-medical purposes and some of the inspection of water beds, and maybe during the pandemic, they use drones for the just public management surveillance point of view. Is there any example that you have drones used for medical distribution?
Supply chain management, as Sir Bhaskar was saying, supply chain management is established in the universal immunization program, and our cold chain management system also is fixed. So nowhere, I don't think that I've come across a situation whereby drones have been used to transport vaccination. At least in my knowledge, it's not there. But the valid point is that what is valid is that we have one of the biggest vaccination systems in universal immunization program in the country. So it's an established system. Only the number wise, for example, every year, whatever we are doing, number of vaccination we are doing in a year, now we do it in a week. Maybe that is the numbers. For example, we do 3 to 4 lakhs a day. So when you are compressing that much, what is the challenge is human resources. the quality, and how do we tackle the whole supply system and logistics. That is a challenge, but all the states have risen up to that challenge, and we are able to provide vaccination. You have heard about 1 million vaccinations a day in many states. So that's now the system has shown the resilience and robustness to deliver that much vaccination capacity. Earlier, for example, Tamil Nadu has a birth cohort of 1 million babies. So we used to have different vaccination schedules. So the numbers which we used to vaccinate, even pregnant mothers, so that numbers now the whole thing is compressed maybe in 2 weeks, the whole 1 year vaccination system. So when you look at that, and then we have a non-COVID vaccination system still going on, the system, I feel that the public health system in my observation has really stood up to the challenge and shown the resilience and robustness, which is very commendable. I'm not that's what I have felt in my experience in seeing how the vaccination system has progressed in the state of Tamil Nadu.
Okay, thank you, Dr. Darez. And over to Mr. Bhuvnesh Pratap Singh. What has been your experience, sir? Because you are a forest state, do you have any distribution challenges?
As I have already stated, sir, that we do not have these drones and all. Neither, as sir has also stated, no one is using it. For us, the distribution challenges are as such not there, because pulse polio immunization, it's a robust mechanism. It exists even in our state. But I'll tell you one thing, so like in my state, like if we see the number of people who are above 60 years and who have got vaccinated is only 46%. Now the challenge for us was to train them to ensure that they take the vaccination, because still 50% of the people who are above 60 years, they have not taken their first dose. So this is the biggest challenge. And for this, under the able leadership of our Honorable CM, we have started different drives. Now we have a mobile vaccination drive. We have small, I'll say hamlets type area. We call it Tola here. So we send our teams, we send our vehicle over there. We have in almost all the district. If in any village we have more than 50 people who needs to be vaccinated, we send these mobile vaccination teams over there. Recently our governor sir has also joined. So his Mizoram, his Tripura experience, he has shared us that we should go door to door visit for the vaccination, because in COVID app, only those who have digital access, they are able to register themselves. But what about those who do not have the digital access? So to cater to their need, we are even allowing that on-site slot booking, which is being done by our people, our officers. So this way we are reaching out to people. We know that vaccine, those who have availed their slots, they'll come. But to ensure that all those, even a single dose does not get wasted, we reach out to them. So our places are in a such way, CVCs, that is vaccination centers, are on such places that where the person who has registered himself in COVID app, he can also come, as well as if I have 5 or 6 doses remaining with me, we have allowed them to call anyone from the village and take up the vaccination.
Dr. T. Arun, we know that Arogya Setu application has helped in tracking and monitoring of the patients, and e-Sanjivani has helped in terms of the online medical consulting or a telemedicine approach. And 3, COVID, as you rightly mentioned, it is becoming a vaccine management point of view. Apart from that, what has been your take on some of the best practices that Puducherry is following?
Puducherry, in fact, in the first wave, when we had the COVID, we had these. There used to be in most of the states there were not home isolation. Home isolation were totally avoided even by ICMR, Government of India. Everywhere was stressing. But based on our own experience, we felt home isolation is the best. When a patient is asymptomatic, because when he's totally asymptomatic, we had forced him to stay in hospital for 2-3 weeks, then discharge him. We had seen psychologically he's totally upset. So home isolation, when we started improving, we came out with an IVRS kind of monitoring. So at a particular point of time, each day, the call will go to them. We will know who the line listing was done. Who is positive, where he is staying. It will be intimated to all the concerned agency, police, revenue, everyone. And finally, what used to happen is every day at a particular point of time, we used the patient used to get a phone call. How about his condition, whether symptoms are there or not. If there is any issue, automatically portal would be generating it. Ticket would be generated. It would be intimated to the local health team. The local health team will go and visit the person at home. So this entire system has really helped even in our first wave, and second wave also we started continuing it. I think we also received some awards for that, technological intervention. This IVRS system has really helped us. Next, we came out with the triaging at home. Triaging at home is a concept which, for example, triaging means whether he requires home isolation or he requires hospital admission. What used to happen is, imagine if I am positive, I will go to hospital for my checkup, for knowing whether I should be admitted or not. So while going, I'll take an auto or a bus or a rickshaw. I'll be in the crowd. I'll spread to many people. So we came out with a triaging at home facility. We used to send our health team to the house to triage. Along with the teleconferences was also done. Each person would be contacted, and we developed an app also, how it has been tracked and all. So these are all the technological intervention which we were able to do. Fourthly, we came out with a dashboard also. I think most of the states have also done, whether any beds are available anywhere on a real-time basis. So that also we have developed here. All these things has really helped us. Technology has helped the healthcare system, has helped the healthcare officials, helped the administrations to make the things available at ease on a real-time basis. What is happening. So the technology is very, very important. And these are some of the best practices in Pondicherry, which I just thought of sharing it.
Thank you, sir. Over to Mr. Bhaskar. Sir, during COVID second wave, we could see the lack of oxygen and other medical critical resources are lacking, due to which in some states we could see that some deaths took place. How you coped up with that experience? How did you manage the infrastructure resource so shortly in Andhra Pradesh? Briefly, if you can share that experience. That is one. Two is during first wave, second wave, non-COVID related medical treatment in public health slightly disturbed. But however, I hope that it is stabilized right now. Government hospitals are treating in all kind of treatments for the public now. If you can elaborate on these 2 points, please.
It's a fact that the current health system that we have, and when I say so, this is for every state in the country and for every country in the world. Current health system that we have didn't have the capacity to cope up with the kind of load of COVID that has come and hit everybody. Let us accept that. In fact, things like COVID happen like once in a generation kind of a thing. And you can't design a health system for taking care of such exigencies, because having a health system to take care of such exigencies every day would be an overkill. So we need to use the resources efficiently and to ensure that we overcome the problems on a day, increase our resources to the extent which is possible, but at the same time ensure that they are used efficiently. That was the thing I think all states had to grapple with, along with my state also. So we increased our capacities to an extent whatever is physically possible. Just an example, before the first wave, the number of oxygen beds that we have in our state was just 3,600. So from 3,600 by the end of the first wave, at the start of second wave, we went to up to 33,000. But even that 33,000, we found it grossly inadequate, in the sense that we had at some point of time around 24 to 23,000 new positive cases coming in. So that was the kind of the load that was getting added to the system that is already fully being totally occupied. So a lot of things were done. In fact, the government of India stepped in. Oxygen production was at different locations, consumption was at different locations. And unfortunately, during the second wave, most states peaked at the same time. For example, Andhra, Karnataka, Tamil Nadu, Kerala, Maharashtra. I think all of us peaked at the same point of time. So there was a lot of problem managing oxygen. So we had to get oxygen from as far as we got oxygen from as far as from West Bengal, from Odisha, from Gujarat. Same Maharashtra got from as far as from Visakhapatnam, from Odisha, and same went true for Tamil Nadu and all. We had issues. There were sleepless nights. There were interstate issues, but I think more or less we could overcome that. There was a one good thing was there was dialogue happening. We were continuously in touch with us. We were in touch with our Tamil Nadu and Karnataka counterparts, Kerala counterparts. We were discussing with them, managing things, talking with other states, and trying to manage the day that we have done. So let me put on record our heartfelt thanks to Tamil Nadu for having helped us with oxygen during those days. So for about 10-15 days, we had really a tight situation. And even Tamil Nadu had a tight situation during the same 15 days. So we managed by having a good dialogue and conversation happening. And the kind of requirement that came in during those peak days, I don't think during a normal course of day, that kind of a demand can be met, or that kind of a generation is also possible, because which was what a general requirement is. After the first wave, we started enhancing in the second wave also we enhanced our oxygen beds. Now we have gone to an extent that we have around 46,000 oxygen beds. But if the same kind of numbers in the second wave come again, and if there are more cases than the second wave, again, similar situations may happen. So we need to manage it point to point and ensure that there. Of course, this time the strategy is that we are putting in local oxygen generation plants in all the hospitals using PSA technology and all. But we don't know. COVID has been behaving quite not the way we would want it to be. So in the third wave, there is a tremendous increase. There could be a tremendous increase in oxygen demand, or maybe it could be the other way around. In the third wave, there could be a situation where oxygen demand might not be that much as happened in the first wave when we developed our infrastructure, but we didn't get an opportunity, or I would say we didn't need to thankfully use the oxygen infrastructure during the first wave. So we are keeping our fingers crossed, keeping our infrastructure up to date, enhancing the infrastructure, and hoping the best that we don't have a third wave per se. And if it happens, we don't require the kind of inputs that were there. But the assessments are being done. There are task forces which have given recommendation. Based on that, we are going ahead with our preparation and all, and hope everything falls in place and we don't have situations that we have seen during the second wave.
Thank you, Mr. Bhaskar. Over to Dr. Darez Ahmed. How tough it was to deal with the critical medical equipment and scary during the pandemic too, sir?
So as MD NHM Andhra was saying that it was a really warlike situation, and it's like every day a category 4 cyclone was hitting us and we couldn't recoup. It's like day after day, like for every, if you have a natural disaster, you get at one point the disaster comes, then you have a recovery, but there was no time to recover. Every day it was the same. So in that way, it was one of the toughest situations I have come across. But now that Sir has documented, like Sir has said, that what are the challenges we face, I would like to talk about the non-COVID health system. For example, like what I observed during this second wave was that, see, the government health systems, for example, deliveries, we have almost 1 million deliveries, 10 lakh deliveries. So the whole government, the load of delivery load also shifted to the government health systems. Many of the non-COVID services got shifted to the government health system. Similarly, even with COVID beds also, 80% of the 70 to 80% of the COVID bed load was taken by government health system. So the biggest learning which when you talk about the stabilizing the public healthcare system is that a strong public health system which is responsive and which can be scaled up is very critical for any exigency, in the sense that, like, honestly speaking, maybe because of the oxygen problem, the private sector could not scale up as fast as the government system could. And it may be a genuine reason that oxygen supply has been compromised, but found that even deliveries, for example, pregnancies or delivery, because delivery is a physiological process, which even COVID is there or not there, it has to go on. So actually what we found is that, say, a strong public government system strength, resilience, and again, I use the word robustness, it's come to the fore when we see that the number of beds is more than 70 to 80% of deliveries and all non-COVID emergencies. And there was a decline in trauma deaths, the trauma and road accidents, even assault, all kind of emergencies, that kind of emergencies, but suicide rates and other kind of emergencies, suicide, poisoning, self-harm, there has been a steady it was there. But again, the whole load has shifted to the government system based on the data which we have. So the lesson and learning is, which for us take home, is that to further strengthen the public health system to deal with the third wave, because at the end of the day, I find that the critical, when the surge and critical this thing come, the easiest and the most robust stepping up happens in public health system. That's our learning.
Thank you, Doctor. Over to Mr. Bhuvnesh Pratap Singh. Sir, how challenging it was for Jharkhand in dealing the two important aspects?
Sir, as has been stated by my previous panelists, sir, it was really tough for all of us. And since the spike was sudden, I still remember 28th April to 3rd or 5th May. I'm sure that was the day when Kerala, Andhra, Tamilnadu, even Jharkhand, we had peak on that week. So that was the worst ever week. I'm sure all those who are in the public dealing, they must be really scary, and no one wants it to happen again. But sir, as far as oxygen was concerned, Jharkhand was the only state in India who was supplying oxygen to outside state. We gave oxygen to UP up till Delhi because we had huge oxygen plant because of the factories which are there, which uses the industrial oxygen. But what I realized, we had enough of oxygen with us, but we didn't have oxyflow-meters. So if I say I have oxygen and I don't have oxyflow-meter, I cannot use it. So we realized that it was not easy for us to, even despite having oxygen, to use that oxygen. So every day we, with our government, with our senior secretaries and all, we used to come up with one decision for that day, and we used to try to implement it. So I'll take one example. We had formulated a concept of COVID circuit. Now, like our capital is Ranchi, so number of cases were more in the capital city, but the number of cases were less in the peripheral cities or peripheral districts. So what we designed was the concept of COVID circuit, in which we merged some 5 to 6 districts, and we merged all the oxygen beds together. So in turn, what had happened, the moment the beds in Ranchi got filled, even they were not available in public as well as in private setting. So what we ensured that all the ambulances, the moment we'll get a call 104 helpline, so we'll just tell them, okay, in other district, at least you will get the bed. If you wait for 5 or 6 hours, there are chances of any mishap, and we could save many lives. So few days later, we came out with mobile Sanjivani oxygen vehicle. Now that was wherever oxygen is not there, we will send our oxygen vehicle. And we use the support of community, because if we didn't had, although we had ambulances with us, we have 108 mechanism with us, but still if we didn't had, we have informed everything on the public platform so that people are aware that they need not die because of the deficiency of oxygen. One important thing during second wave, which I realized, because now the very scarce resource, doctors are really a scarce resource. And as far as planning for third wave was concerned, so I realized in my state, I have only 142 pediatricians. So if we see cities like bigger cities like Bangalore and all, in one suburb we'll be having more than 200 pediatricians. So in this whole state, I have only 142 pediatricians. Similarly, the people who know how to use ventilator, we got the ventilators, but we didn't have people who know how to use the ventilator. So the challenges was to train them. So all that challenge we faced, we trained them, and luckily things went pretty well. And I'll say for third wave, because the moment some problem is there, if we take decision, howsoever short it is going to help people, because people expect a lot from us. And finally, 104 helpline was there. We started with 6 people sitting on the helpline, and we increased it to 35 helplines. So every day some 100 people were sitting there to take the call. All of them were lab technician or some paramedics. Their only role was to talk to each and every person who is in home isolation. It was the home isolation because of which we could tackle this way, second wave. And that's from my side, sir.
Thank you. Dr. T. Arun. So how do you manage the supply chain management? I mean, how do you manage the supply chain management for distribution of vaccinations from central government to the patient level? Can you elaborate the process?
So it is decided by the government of India, which state, how much is required. So initially, they used to give wherever there is more consumption, more demand. So now what the government of India has done from July, I guess from July onwards, is on a monthly level, they are putting up the status, how much to give to a particular state. This is the basis. How they decide on the providing the vaccine is based on the consumption of a particular state and also on the wastage. Wherever there is more consumption and less wastage, they are giving it more. So this is at the level of the central government level. At the state level, the same thing we are also adopting, where whichever districts is doing better or doing consumption is more, we are trying to give it more, because we want to give it to the consuming districts. So same thing we are doing at the PHC level also. A particular PHC, there might be huge demand, crowd might be more, people might be more, demand might be more. So there we are giving it more. So the same model, all these things are tracked with the help of the COVID portal. So with the help of, say, at the end of the day, I can extract region-wise, PHC-wise consumption of the vaccine on a daily basis. So this is how the entire distribution is planned.
What is the needful demand of the Puducherry in terms of number of vaccines, sir?
We have eligible beneficiaries are around 10 lakh, that is about 18 years. So this is our total demand. We have completed almost 50%. So still long way to go. There was some sort of a hesitancy in the beginning, but now it has improved, and now people are coming forward to take vaccines.
So when do you think the Puducherry to become 100% vaccinated state?
No, we have planned it by August, but it's all depend upon the supply also. As I was saying, how the supply stream is, it all depends on the supply also. Of course, what has happened in Puducherry is initially there were elections, they were busy with election. Next, there was some famous actor died in Tamilnadu. Puducherry and Tamilnadu are like share the same language, share the same cultural this one. So that hesitancy started coming up here, not just here Pondicherry, but also in Tamil Nadu. So if you see at the national level, both Tamil Nadu and Pondicherry are at the same place. So a lot of efforts have been taken to remove those barriers, remove those hesitancy and reluctancy. So now we are moving up, and I think more than 50-60% has been vaccinated already. 60% has been vaccinated. Almost 6 lakh people have been vaccinated. So maybe in another couple of weeks or in a month or so, we might vaccinate everyone.
Thank you, sir. For my final question to you, Mr. Bhaskar. So taking experience from the COVID, most of the state governments have ambitious plans, and they wanted to strengthen the medical infrastructure and expand the services to last mile connectivity. And I'm sure Andhra fortunate to get adequate funds to ramp up the infrastructure. So for this financial year, what's your blueprint and roadmap, sir?
Investment in health is a long-term thing. It's not that we invest this year and we don't do next year. We have not been, when I say we, it means entire country, we have not been investing in the health infrastructure the way it should be done. It is far below what is required, both in terms of physical infrastructure, in terms of hospitals, and then equipment, particularly the manpower. So our health institutions are quite understaffed, even as per the norms. Availability of the doctors and paramedical staff itself is an issue, more so for the doctors and specialists, because of the quite difference in the pay package that they get in the private sector and the government sector. That's a challenge, but from the time COVID hit us, so we could increase our HR in the sense that we have ensured that all the vacancies we have completely had. So as on date, all the sanctioned posts have been filled. And then apart from that, we have ensured that the cutting edge level, all the PHCs have at least 2 doctors and 3 nurses. So they operate on really on a 24/7 basis, and it actually happens. And in terms of physical infrastructure, this year we've been lucky that the state government, because of the exigencies as well as for the long-term vision, have supported us substantially. Our investment in physical infrastructure has gone up by many times. In fact, this year we are building 14 new medical colleges with attached hospitals and nursing colleges. So till date, the number of medical colleges in government sector in Andhra was only 11. So can imagine that we are adding 14 this year. That's a huge quantum jump. And apart from that, all our other institutions like our district hospitals, our taluk hospitals, which we call different terminology, are all being spruced up at a cost of another 4,000 crores. Our total investment over the next 3 years only on the physical infrastructure, including the equipment, would be close to around 18,000 crores in the health sector. Apart from the HR that we've already done, and we need to add some more HR because of these new institutions coming in. So a lot of investment is actually going into the sector, and it's the correct time. I think that is a need of the hour that more infrastructure is required, because we're grossly underprepared, not for COVID, not only for COVID, but our investment in health infrastructure till date has been low. The number of doctors we have for the population we have, and the hospital beds that we have for our population is quite low. It is high time that we start looking at it in a more objective manner and prioritize these issues. I think that is, if we have learned anything from COVID, is that we need to invest in the health sector. Thank you.
Thank you. Thank you, Mr. Bhaskar. Over to Dr. Darez Ahamed. Your blueprint priorities for Tamilnadu for this year, if you can.
What I found is that the importance of public health informatics, and how do we have a strong intelligence system, and having a population health registry. For example, what I'm trying to say is that we have been seeing that now our institutions, we have been catering to people who have been walking into our system, and it's like an institutional care system which we have. So what the experience which we had in COVID and the pandemic, we understood that it has the community which is the biggest challenge. Unless until every facility understands the community it is taking care of, the denominator it is serving, then only it can really serve the population the way it can. So what Tamilnadu is trying to do is to have a denominator-based system. For example, every PHC is to understand which are the families which they have to take care of. A strong public health, a unique health ID system, whereby every person, every individual has a unique ID, and we'll try to trace it as a public health system. So once we know that, we have a strong modeling in place to understand, for example, even a dengue outbreak or a fever outbreak or a diarrheal outbreak. So a strong, for any emergency, what we need is a strong public health information intelligence system. And that system should be robust enough to take really understand and see the patterns of changes across the system. For example, now we have a zero surveillance data and we have genome sequencing. So both of them gives you some idea like which are the most vulnerable patterns, in the sense that at least how much zero surveillance, our zero surveillance data is spread across from 40% per district to 80%. So it's a huge band of like zero surveillance is the, like what is the zero positivity rate, how many people have some immunity against this virus. So when you have that kind of a system, you need to have a predictive modeling analysis done for different districts to understand that how do we manage the lull period. So the lull period management is what TN has been trying to do, to have, for example, do we do a prospective contact tracing or a retrospective contact tracing. So that's what, when the wave is coming, or you understand that how the system is going to respond, we need to have some modeling in place. The strength of modeling in the government system should be very robust to understand that what is the different kind of worst case scenario predictions, to understand what will be my requirement of oxygen beds, even the susceptible. Different models are used. For example, Sutra uses, IIT Kanpur uses one model, then you have the SEIRS model. So see, different modeling systems to understand. So that is one very, very important thing to have, that predictive modeling. And we may go wrong very badly, but still we should have some systems in place to see that, okay, so like even in dengue or any kind of outbreak management, emergency management, we should have a strong public health information, and you should have a denominator based system, so that every facility knows what is the population it is taking care of, so that they can really link across the system. For example, Tamil Nadu is the only state which has not used rapid antigen test. It has used RT-PCR, and as you know, RT-PCR is a little lab technician intensive system, and transporting the sample. And really, one thing which has really stood out for me, learning for me from this system, was that like our capacity to have an hub and spoke model for diagnostics. Like as every state has an essential drug list, now the kind of transportation of diagnostics which has happened across from the primary health center across to the RT-PCR lab, like that gives a confidence that a hub and spoke model for a diagnostic system is the way forward for the state. And the blueprint, when you ask for the third wave, like what I would like to say is that, see, we have learned a lot from the first and second waves. What will be that every district or every block, even the block level, we need to watch, so that any system, for example, when you say that many of the districts are less than 100 cases, so now how do you keep it less than under 3 digits, like to have a contact tracing and to make sure that the new cases are coming from the contacts, not the fresh cases into the system. And if the fresh cases are coming in, then the alarm bells has to go up, and we should start having a better like how do we, for example, if the TPR crosses 5, when TPR crosses 10, what is the mechanisms to be put in place to tackle the third wave? So that is one thing which we would like to that's what we have been doing. Our task force also recommended the same thing. Then future emergencies, a robust public health information system and modeling so that they can predict the trajectory of different emergencies. For most of them are communicable or even non-communicable emergencies. So that's our learning, and that's what I would like to say about having a strong information systems.
Thank you, Dr. Raj. Over to Mr. Bhuvnesh. Your priorities and blueprint for Jharkhand for this year.
Sir, I think most of the points have already been covered. For us, the priority is similar. Like we are presently in my state, we have only 90 cases. To ensure that all those who are suffering from COVID, we are doing the contact tracing, but also to ensure that none of the new people enter the state having corona and all. So we are going for mass surveillance at the district entry level. But as we have seen during first and second wave, all these activities don't help much, because the moment it peaks suddenly. So what we have also started doing is we are making private partnerships to work along with the public partners. We have agencies like CCL, ACL, NTPC. So we have aligned our goals, their goals, and as well as the private hospitals' goal with that of the state goal. We have done a complete gap analysis for each district. We have done like how many beds we need, in case of worst case scenario, let's say if we say the positivity rate is 10%, because till now we have seen in any of the district in Jharkhand, the worst case was 10% positivity. So if we get that much cases, so that many number of oxygen beds should be there. We have also devised a ratio 1:2:4. That is, if one is ICU bed, then twice the number of bed will be oxygenated, and then so on and so forth. So and similarly, what we have done is we have informed the private sector hospitals that these many number of beds should be available in their premises too, so that they should be ready for any mishap if it happens. During second wave, we found, I'm sure in almost all the states, it was seen the drugs like remdesivir and all. Suddenly there was a shortage, and I can also say that while discussing with doctors, suddenly the name remdesivir propped up, and within 5 to 10 days, there was huge demand of remdesivir. And we found, because people were panicking that they want remdesivir, and we saw many things. So what we have done now only is we have done a detailed analysis of the drugs which we may need in the upcoming times. As Bhaskar sir has already stated that we cannot predict what COVID will do. We are preparing for oxygen, we are preparing for something else, and maybe some other form may erupt. So we are not aware. But what I am saying is that whatever we have learned in second wave and first wave, like the number of drugs. So what we have learned is like to ensure that there is no panic. So we are I have calculated, we need 80 lakhs paracetamol drops in the state. So now this is in case of the worst case scenario. For that, from the government side, whatever tenders and all things we have to do, we have already done it. So basically, we are going for a holistic plan, and I'm sure if third wave comes, so we'll be able to tackle it. And that's from my side.
Dr. T. Arun, as part of the strategic priorities on every state expanding, putting their blueprints and expanding the health infrastructure in order to strengthen the healthcare service for the benefit of the people. Just can you highlight how Puducherry's roadmap is in pipeline?
Yeah.
What are your plans to enhance or strengthen your healthcare systems in Puducherry?
Thanks to COVID, throughout the country, the entire healthcare infrastructure has been ramped up to a very, very great extent. We also, after the first wave, in the month of October or so, we came out, in increasing our oxygen beds and all. We came out with a concept called Uir Katru. Uir is life, Katru is air. That is Project Oxygen, also called Project O2. Under the leadership of our Honorable Governor, we started augmenting our oxygen beds. If you see, our prior to April 2020, in one year back, we were having only 300 oxygen beds. Whereas now we are having almost 1,800 oxygen beds. We have increased almost 5 times. So that is one. This year we are having ventilators. So in the month of November, December, we established 6 PSA plants, through Government of India, and some LMO tanks has been increased. So augmentation of oxygen supply, oxygen beds, and other oxygen related equipments like ventilator and all has also been done. So we have almost scaled up. Even in our medical college, we were having only 20 ICU beds a year back. Now we are having 150 oxygen beds. So means ICU beds. So we have augmented all our facilities, including private, including our CHC, PHC, oxygen concentrators have been placed at all the PHC level. And in second wave, we could not find any, shortage of oxygen beds in Puducherry. Thanks to all these efforts, even in the peak of the time, when our cases were around 2000, we were not even having any, shortage of beds. And one more thing is, in Pondicherry, even Tamilnadu patients also come and get admitted. More than 40% of our admissions in hospitals are from outside states like Tamilnadu and all. So we have augmented our facilities, and because of the third wave, we are focusing more on our pediatric wards, pediatric, facilities and all, pediatric ICU, pediatric wards, ventilators, everything we are doing it. So we are all we are ready with to manage any kind of crisis, any kind of third wave or any such wave in future.
Can we consider Puducherry is a future-ready state so that they can face any future crisis if they come?
Yes, we are totally ready to face any crisis that comes in the future.
Thank you very much. I must say that, congratulations to all the administrations. They have done a commendable job and really, put an example, the situation, everybody rising to the occasion. With this, I sincerely thank all the panelists for joining the panel discussion, State Blueprint, Tech Roadmap for COVID-19 Vaccination Drive, Supply Chain Management. I sincerely thank Mr. Bhaskar Katamneni and Dr. Darez Ahamed and Mr. Bhuvnesh, Pratap Singh and Dr. T. Arun for joining the panel discussion and sharing your knowledge with us. Thank you very much, sir.
Thank you everyone for sharing your rich insights. Let's proceed further. Stay tuned.